Hello, my name is Katie Breitenmoser. I am 75% of Windyhill Midwifery, and I'll explain a little bit more about who I am and what we do, but we do exclusively home birth as of right now in the north central, north central Wisconsin. And the reason that I started putting this presentation together and offering it to local municipalities is because if we have a home birth transport, I sort of got tired of people walking into me and like, ooh, what's going on here, and who are you, and what do you do, and what do you want from us? And it ended up taking just time and resources, and it doesn't need to be that way. It can be more streamlined. So if you guys walk into a home birth transport situation and understand midwifery, understand what we do, what we don't do, and then what we need out of you, which usually is a fast ride from point A to point B, it streamlines everything and makes it a much better experience for the consumer, which is my main focus, and then for us as well. Bear with me because the presentation software that I normally use wasn't loading my images properly, so I'm moving to something else, and I'm not sure if this is going to be a little janky, but we're just going to roll with it. Uh-oh. Okay, we got something here. So first of all, we'll start with what midwifery is. So a midwife is not an OB. We are not medical providers. We are just here to assist a process that normally unfolds relatively easily, and our main, 90% of our job is waiting, and then 3% is catching the baby, and then the rest of it is cleaning up. And we are really just there to assist and support. This is going to be the janky part. Okay, so it's supposed to say CPM, which is Certified Professional Midwife, and that's our credential. That's a nationwide credential, and that's governed by the North American Registry of Midwives. There's standards of education and continuing education that we have to, keep up with to keep our certification. And then with our certification, we are able to add LM behind our name, which is what that's supposed to say, and that's licensed midwife. So I'm a CPM, LM. And licensed midwives are governed or overseen by the Department of Safety and Professional Services in the state of Wisconsin. So our scope of care, that worked out okay. We provide full spectrum prenatal care for low risk families and some moderate risk families based on if we have appropriate collaborative care. So we do not do high risk, and we risk people, we are doing ongoing risk assessment for the families that are in our care, so that if somebody has hypertension, or somebody develops gestational diabetes, or somebody has a congenital situation that we should not be doing a home birth, we identify that family, risk them out of our care into physician care. So that's 90% of what I do prenatally is making sure at every single visit that this family remains low risk. We can order and draw all labs that are pertaining to the childbearing cycle that they would draw in the hospital. So we do our own phlebotomy. I have a mobile centrifuge in my car so that I can just, be drawing labs at an Amish house, spin them while I'm driving down 29 and drop them off at our lab. So we do all of that. We can order OB ultrasounds, and then we refer out for any abnormal. So if we have somebody who's chronically anemic, we refer to hematology, we refer to OB for that. If we have somebody who develops other pregnancy complications, we can identify that and refer them out. Labor or birth, we are doing exclusively home birth now, although we're working on a birth center project in the Merrill area, which is very exciting. So because of that, we carry all our stuff with us as if we were set up to do a normal low-risk vaginal birth. Everything that they would have in a hospital delivery room for a low-risk birth, we have in my car. Again, in labor and in birth, we transfer for a yellow flag. If we have a couple yellow flag indications or one red flag, we're going to transport out. And then if a sudden OB complication comes up, our training is to stabilize and transport. Postpartum, obviously, we're taking care of the baby. We're also taking care of that mom. So physical recovery, breastfeeding support, doing weight checks on the baby, making sure that everybody is happy and healthy, and then doing the regular, routine state-mandated newborn screening. So we do the foot poke and the screening for congenital heart defects and the hearing screening, all of that. So what are we specifically? Windyhill is mostly me. I'm the owner and the primary midwife, although I did hire Hannah, who is staff midwife. She takes about like 1/4 to 1/3 of our client base. She would have as her primary clients. The rest are my primary clients. We have a student who tags along to all my births, and then we have one person behind the scenes like doing statistics and data collection and contacting people with their lab results. So we're a pretty core team, and because of that, I wear all the hats. So I'm the receptionist and the phlebotomist and the janitor, and I'm oftentimes driving Amish around because that's what we do. I have a home office, so it's just a small, cute little space. I like to keep it small and homey so that if any of my families have sort of, other birth trauma or other like medical trauma, maybe that's a little intense for them to be having their blood pressure taken in a clinic setting, we have a nice sort of home-like feel. And we can do everything in my little office that they would do in the clinic setting for normal prenatal care. I have an ultrasound come once a week, so we contract with a third-party radiologist. It's not just like me in my basement doing weird little ultrasounds. It's, it's an up and up thing here, folks. So we serve, how's that gonna work? Okay, about 20% of our families are Amish. I would say a little less than that right now, maybe 15% are Amish. So we can, on that note, do a birth from start to finish with no electricity because we have to. The demographic challenges there are obviously no electricity or cars. It's a pretty low socioeconomic category, and we have like really high parities. I've caught baby number 15, 16 for people, and so with those high parities come some challenges like postpartum hemorrhage and malpositioned babies. Because they're sort of like living well under the poverty level, we have nutritional deficiencies and a lot of genetic disorders. 40% of our population, our demographics are Mennonite or German Baptist, also, sort of another subsect of the Anabaptist collective. They have electricity and cars, some wealthier families there, but still a pretty low SEC on average, still dealing with a lot of genetic disorders and high parities. But then 40% of our families are English, and that's what they would call us. We're all English. And in that category, we have everybody from factory line workers to lawyers and surgeons. It's not like there's not this one little narrow demographic of people who choose home birth. It is a widely growing demand. So I really want everybody to get that through their head because we deliver a fair amount of babies up here. And thankfully, I don't recognize any of these faces, which means cool. But you never know. I think most of the challenges in our English families is their lack of support once they've had a baby. Like everybody's done the baby shower and they're like, oh, you had a baby. And then they just like sort of drop off the map as far as supporting that family after they've had a baby. So we run into those challenges. And then, of course, I think we're all sitting around probably too much. So that creates some pregnancy and birth complications, just the sedentary lifestyles. This is sort of a graphic of where we travel. So Merrill is home, and we deliver a lot of Amish and Mennonite babies in this area. And there's a growing Amish population out by Anago, so you catch a lot of babies out there. And then North Rhinelander and Tomahawk, we're there a lot. North by you guys, not quite so much, but still enough. So I'm going to spend a little time on why people choose home birth because I don't want you sitting here thinking that it's just the crazies. There are some crazies, don't get me wrong. But why do people choose this? It's not as off the wall as people think. First of all, we're there to facilitate the normal physiology of birth, and physiology of birth is pretty solid. I mean, we've been doing this for millennia. Babies just arrive. And so what we're doing is supporting a normal process. And we do a better job at that than the hospital does. I will tell you that unequivocally. We have a lower rate of interventions. Because we're not trying to institutionalize a process that should be really individual, we don't have to intervene in a way that the hospital mandates. They're not going to let somebody labor for longer than this X number of hours without adding Pitocin. They're not going to let somebody, sort of decline postpartum Pitocin. There's just a lot of things that they do as per policy that we're like, yeah, we'll do it if we need to, but it's not mandatory. So in other words, we get autonomy as independent practice providers. We get autonomy and we get to pass that on to our families, and people appreciate that. And then the other thing that we do a really freaking good job at is providing informed consent. We are going to cover, over the course of your prenatal care and your labor and birth and your postpartum care, the full range of people's options, not just what we think that they should do, which is sometimes the informed consent that people get from doctors in hospital settings is, this is what we want you to do, and so this is the option we're going to present. We provide everything and talk about the risks and benefits of all people's different options, and that's refreshing to a lot of people who are sort of tired of having decisions made for them. And generally speaking, when you talk through all people's options, they pick the smart thing anyway, but then they feel like they've picked it, and it wasn't decided for them. We don't take care of just the clinical profile, we take care of the whole person, and that is something that I think is really lacking in medical care right now, is you walk into your prenatal appointment and you spend 15 minutes with the nurse and she takes the vitals, and then the doctor comes in, you maybe spend 3.5 minutes with them and they ask if you have any questions, and you say, yeah, and then they say, and then they walk out the door. We try and take care of the whole person. So we schedule a full hour for appointments that we can talk about not just what your blood pressure is doing and there's a little bit of protein in your urine, but all right, so do you still have a job? Or, I heard that was sort of dicey last time, what's going on there? Or, how are things with your husband right now? Or, did you find a place to go with the kids when you go into labor? Like all of these other factors that aren't as peripheral as we think they are. It all factors into a healthy birth and just a healthy family. Continuity of care. Surprise, surprise, people like to meet ahead of time the person that's going to be staring at their vagina when they push a baby out. I don't think that that's unreasonable. So the fact that the person they've come to know over the 7 to 8 months of their prenatal care is the person who 99% of the time is going to be at their birth is appreciated. And then also the person who's at their birth is doing their postpartum care. So if the birth was really challenging or something happened that we had to manage, we can talk about that afterwards at the next 24-hour visit when we see them, be like, that was a big deal, how are you feeling about that? Or, is the baby latching better now that we've got 24 hours under your belt? All these things that, if you didn't have that continuity of care, you wouldn't be able to ask those same questions or give that same support. Affordability, I don't like to be top of the list because I don't want anybody choosing out of hospital care because it's cheap, although it's way cheaper than having a birth in the hospital. $11,000 to $15,000 is the average in the state of Wisconsin. Our total package right now is $3,700 for labor or for prenatal, labor, birth, postpartum care. There's extras mixed in there, so I would say the average person spends about, I would say, $3,000 for a full course of care, which is a pretty significant savings. And then a lot of people choose us because they had poor hospital experiences. And people come to us with all sorts of birth trauma. But I've had people on the phone saying that I will never go back to the hospital. I had sexual assault in my history that was less traumatic than my hospital birth. And that's a really big deal. So because we have autonomy, and we get to derive our own policies and procedures. We get to tailor the experience to the individual, and that really helps to remedy a lot of that birth trauma. But is it safe? If you're looking at well-conducted studies, in other words, studies that compare low-risk planned hospital birth to low-risk planned home birth with a licensed well-qualified provider, the outcomes are stunningly similar. So there have been other studies that show a pretty big discrepancy between hospital births and home births, but that home birth category, when you dig into the numbers a little bit, you find out that they're counting all out of hospital births, whether or not they were with a licensed provider, whether or not they were planned. They're counting, that baby was born precipitously on the side of the road, or the baby was born to a drug-addicted mother who didn't want to go into the hospital for obvious reasons. That's all lumped into the home birth category, and you can guess how that would skew the numbers. So when you're looking at proper studies, yes. And the reason that it is safe is because we continually do risk assessment to make sure that people who are birthing at home belong birthing at home. We consult or collaborate, like I said before, for any elevated risk factors and transfer if we need to. And we track our statistics in way more detail than the average hospital practice. So I could tell you on a percentage, obviously what our transport rates are, our risk of postpartum, our rate of postpartum hemorrhage, our rates of I track everything down to the position that the mom was in when she gave birth, and the position that the baby was when they came out. So it's really nice to be able to back what we do up with really solid numbers and really effective transport rates, stuff like that. And then we report and review for sentinel events. So if we have a postpartum hemorrhage that results in a mom with signs of shock or a mom who receives blood products, we report that. We voluntarily report that, and it gets reviewed with a group of our peers so that we can receive constructive criticism. We can amend the way that we do things, maybe put different policy protocol into our workflow, and we learn from every challenging birth. So the certifications in continuing education that I do, first of all, obviously stay current with our CPR and neonatal resuscitation. So we take NRP that's very specific to an out-of-hospital setting, so that if we have a baby who needs some help, because we don't have like a button on the wall to press and get the entire NICU team in there, we need to understand how to stabilize that baby, how to prepare them for transport, how to get them to that higher level care in an effective, efficient way. We do birth emergency skills training, which is just what it sounds like, birth emergency skills in a low resource setting. I do advanced life support and obstetrics, which is a AAFP class covering emergencies that are far beyond what I would manage at home. The reason that I maintain that certification or that education is because if I have a family that risks out of my care for preeclampsia for whatever reason, and I need to send them in or transport them in, I want to be able to translate what's happening so that they can, have somebody there as their advocate, or have somebody there just explaining what the next step is and what people are offering them, and then it just helps maintain that continuity of care, give them somebody there to just ease that transition from home birth to hospital. Breech training, I maintain my breech training, and there is a program called Breech Without Borders, who does a phenomenal job of teaching physiologic breech. I maintain that because, sometimes you have directionally challenged babies, and if you are expecting to see a head and instead see a butt presenting, you better know what to do, because if we're up in Manitowish waters, it's not a very expedient transport, so best know your shit. We have a lot of demand for water birth. We have 3 birth pool kits that we lend out to families that are inflatable. It takes about 100 gallons of water to fill, but that means we can provide water birth to pretty much everybody. I've set that thing up in Amish houses. That's the upper body workout. You're bucketing all that. And then stable. Stable is a post-resuscitation, pre-transport stabilization of neonates. Basically, if we have a compromised baby that needs to get to the NICU, how do we prepare that baby for transport? How do we, what do we need to assess? How do we make sure that that transport is as smooth as possible and that baby is getting everything that they need, even en route, so that we don't end up with a baby on the receiving end whose blood gases are shit and they're cold and they're going to have a hard time working with that infant, versus if we're supporting that baby the whole step of the way. So that's I would say that's the certification that I try to keep most current with. There's all sorts of other stuff mixed in there. Okay, what comes along, does anybody have any questions before I keep going? I feel like that's a lot. Okay, so all of my stuff is in my car all the time because we might get called at any moment. And I put together a little, let's see if this works. I put together a little video showing what we do bring. Oh, hold on. Okay, if this isn't gonna work. Wow. Okay, hold on. We're gonna do this another way for a hot second. Bear with me because it was loading in here. Okay. See if we've got volume, because this is just what comes along to a home birth. it's not gonna work, is it? Okay. Well. Okay, so this is the dumbest thing. So the big bag is my labor bag. It has everything that we need. If we're only gonna pick one bag as we're running in a house because things are happening quickly, that's my bag. It's got all my hemorrhage medications. It's got my ambu bag for basic resuscitation. It's got all the disposable stuff that we need, Chuck's pads and God's pads, and everything that we would need for an imminent delivery, sterilized instruments, sterile and non-sterile gloves. The smaller bag is my neonate bag, so that has everything that I would do, everything that I would use for baby at a birth and then at the postpartum visits that we do afterwards. I have a birth stool that assembles, that's just this really clever way to get a mom into a supported squat position for birth, which is lovely. And then the prenatal bag is that leather one that has everything that I need to go and do home visit prenatals. And then what's not pictured there is my resus bag, and we'll talk about that a little bit more. Poop, I'm really grumpy that this movie isn't playing, but here we are.
Is it a video?
It is a video, and I put a stupid amount of work into it.
We like videos.
So I know, so do I. Well, here we are. Oh, guess what? See, look at that jumbled mess. Any questions about who we are, what we do, what we carry? I'll talk a little bit more about the meds that we have on board, but questions for me about Windyhill? Okay. I must have done just a really good job there, or people are asleep. Okay, so then the next half of this, we're going to talk about OB complications. And we'll start out with just regular how to catch a baby, because I would say that's probably what people are going to run into more. Like somebody had cramps all day, but they thought that it was just the Mexican food that they ate last night, and they didn't realize that they were in labor. And now, holy crap, I think this baby is coming. So they call you guys. You come. Somebody's pushing a baby out. What do you do? If it looks like you're going to be in charge of catching this kid, first of all, ask, these are the things to ask when you walk in the room. Is this pregnancy at least 37 weeks? Because that's going to influence some of how you take care of this baby. Ask if there were any pregnancy complications, because that's going to tell you a little bit more about what vitals to take and how important some of those things are. 3, any history of prior complicated births. And a lot of this you're asking just that you can update whoever's en route. Do you need a NICU team on board because they knew that this baby had some sort of a defect? Do you need paramedics on board because she had a history of postpartum hemorrhage? Those are all things that I think, those are the top 3 things that I think you should ask. And then please just assume that this is going to work, because childbirth works the vast majority of times. People push babies out all the time, and they can do it without anybody in the room. Most of the time it's going to be okay. So encourage everybody just to take a breath, because it's going to downregulate your nervous system. And let's face it, you're all getting a little fidgety there. You're like, I don't know if I want to do this. It's a normal physiologic process. One of the best things that you can do is just encourage this mom to hold off on pushing. You don't have to be frantic about it. You're like, please don't push, please don't push, please don't push. Just be like, just hold on. Just hold on. Your body will push when it's time. And that's true. If you tell that mom to just hang on, just don't push until she absolutely can't anymore, until her body just takes over, then that's the time that's right. That means the body and the baby have worked together. They've got all the pieces of the puzzle into place, and that baby's going to come out just fine, vast majority of time. And then the next most important thing is let that mom move into whatever position she wants to, because pushing babies out on your back in bed is a relatively new phenomenon. Doctors invented that. Males invented that. People without uteruses are the people who decided we should have women laying down to give birth. It restricts the pelvic opening by up to 30%. So let's just let the mom choose whatever position she wants, because she will physiologically do whatever she needs to do to get that baby out. Let her move. Unless you're in the back of an ambulance, in which case she probably should stay on the little gurney. Whatever. Even little stupid things, like if she's on her hands and knees, she might just move one leg to get into more of a runner's pose. That changes the diameter of the pelvic opening. That baby's just going to come right out. As that head is coming, oh man, you guys, this is really irritating me. So encourage them to breathe the head out. You don't want anybody to tear unnecessarily. If you're like, push, 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 to try and get that head out in like Mach speeds, you're going to cause a tear. Let her just breathe the baby out. It's okay if that hug comes slowly. They were meant to come slowly. It's okay. And then it's also normal to let that baby, once the head is born, it's normal for that baby to sit on the perineum. That's what we call, a baby who's like head is out, and they're just like sitting there. This is the perineum, and they're just like hanging out there for a little while. That's okay, because what happens when they're hanging out there for a little while is like all this mucousy stuff starts coming out of their face, their nose and mouth, and that's what happens when they have to like sit there with that tight squeeze for a hot second. That's a normal part of the process. And then what you'll see is they'll do a 90-degree rotation, so they'll come out, usually with the face toward the mom's rectum. They'll come out with the back of the head facing up, and then they'll make this groovy little quarter turn, 90-degree turn, and then one shoulder and then the other shoulder, and then they're out. But it's okay if they sit there for a second until the next contraction, and then she pushes with the next one and gets those shoulders out. That allows them some time to clear their airways. So watch for restitution, that's that turning. And then as that baby starts to come, here's something that you guys are probably not taught. If there's a nuchal cord, it's not a crisis by any means. In 18 years of attending births, I have never had to cut a nuchal cord in order for that baby to be born. Because all you have to do, if that baby is coming and there's a cord around the neck, if it's stunningly loose, you can move it over if you really, really can't resist the temptation. But if it's snug, all you have to do when that baby starts to be born is keep the head towards the maternal thigh and somersault that baby right through. So now, if she's pushing that baby out and that baby's got a nuchal cord and you let that baby come this direction, that's going to pull tight, right? Like we all know that. That's basic physics. But if that cord is around the neck and you keep that baby's head close, you're keeping slack in the cord there, and now you unwind it after the baby's out. Because here's the thing, if this baby starts to have any compromise, you want the cord intact. You don't want to clamp and cut here and then have a baby that is hypovolemic that you need to resuscitate. I think I have that somewhere else.
At what point do you start suctioning to clear the airway of the baby?
I never suction.
Never, okay.
Not never. I have
You got all this
suctioned.
mucus and stuff there. If head comes out, you don't do anything at that
Okay,
point.
so think about millennia ago when babies are born in the hinterland, just like out in the woods. Was there a bulb suction there? Like there was no, like this when like the baby popped out and then the bulb suctions so that you can clear the airways. They're very good at clearing our own airways. A neurologically intact baby is going to clear their own airways. You can.
We don't have as many stillbirths as we had 100 years ago at all.
Well, stillbirth is different though.
Yeah.
Yeah, that baby's, there's no help in that baby. There's no suction in that baby. But so when they're on their way out, if you catch that baby and you unwrap the cord and then you hold them there for a hot second, this is called postural drainage. So if you can keep that baby just for a little second in the sniffing position and at a 45-degree angle, just let them chill there for a hot second before you hand them to mom. That postural drainage, that position is going to allow them to clear secretions if that didn't happen here at this stage. The only time that you're going to want to clear an airway is if you're looking at possible resuscitation. And we'll talk more about that, but that is a very good question. If I don't answer that, holler at me.
Okay.
When that baby is coming, if any of you pull on a head, I will track you down. I will track you down. You don't need to pull on that head. And we'll talk a little bit about, the dreaded shoulder dystocia and how to identify that and how to rectify that. You're not going to get anywhere pulling on a head. You will cause neurologic damage. Okay, so then that baby pops out. You've unwrapped the nuchal cord. You did not clamp and cut it, and that baby is going to go right to mom. So it's really important. Skin on skin for babies is just pivotal, because this mom has been breathing for a number of years now and it's well regulated in her. If you put that baby on here, neurologically you're helping that baby regulate. You're helping them regulate their respiratory rate, their heart rate, even things that you would never imagine, like their blood pH. There are studies that prove that their blood pH regulates faster with skin on skin. So put that baby right up where they belong, cover them in a towel, that's all you need to do. The umbilical cord should be intact. So when a baby is born, they've got that tight squeeze through the birth canal. And we don't know, it's suspected that by virtue of that tight squeeze, up to 25 to 30% of the blood volume of that baby is retained in the placenta at the time of birth. So if when that baby comes out, you're clamping and cutting the cord, you're robbing that baby of like 25% of their blood volume that was warm and pH balanced and perfectly tight for them. If you left 25% of your blood volume somewhere else, would you feel good or would you feel like shit? So if we're going to expect this baby now to transition to life on the outside, let's let them do it with a full blood volume. It helps their lungs expand better because the capillary action that like pulls open the little alveoli of their lungs does better with a decent blood volume. It helps them regulate their temperature better, like all these things. If you clamp and cut that cord, you have robbed them of that and created a hypovolemic baby that now you have to deal with. When that baby is born, you can wipe the face if you need, just in case they need a little help breathing, because you want to have a nice dry face to resuscitate. The vast majority of times you don't need it, but it does help them clear some secretions. It's okay. And then you just cover them on a baby, keep them warm. I don't put hats on my babies because A, they're usually born a little warm and they need to cool off just a hot second. B, if they're on mom's chest, they are thermoregulating that way. And then C, it's actually really important for the mom, and this is going to be sort of weird, but for that mom to smell her baby and experience her baby without a hat on is important for the foundation of her lactation. So there's all sorts of hormonal things that happen when moms are like this close to that goopy, slimy baby. Let's not rob anybody of that. Okay, so a baby who's doing well, because they all come out looking just a little dicey. So you can see like this baby, there's some obvious cyanosis here. This is a fresh baby. This is a baby who like had a little protest poop right on mom here. You can see that like there was a robust cord that's intact and a little bit of cyanosis going on. They come out looking purple. They come out looking a little goofy, and that's okay in that first minute. There's a reason that we don't assign APGAR scores until the end of that first minute, because they should have that first minute to start that transition before anybody's just really harassing them. This is that same baby at 3 minutes. You can see the trunk is starting to pink up, face is pinking up, still some peripheral cyanosis, that's okay. Same baby at 10 minutes. So this you can sort of tell here, like the cord is much more flaccid in these two pictures. This placenta is already out, which is the only reason that I'm clamping and cutting it. But that baby at 10 minutes is looking real nice and pink. And that same baby at 1 hour has a little bit of a blue tinge in the hands, and that, you know, peripheral cyanosis can come and go. There should no longer be any central cyanosis. Questions about what a baby is supposed to look like when they transition? In the immediate postpartum, so if she's had this baby and you're transporting, if you can facilitate this mom nursing this baby, do it. Because when moms nurse babies, it creates this oxytocin like rush that is so good for helping that placenta come. And it's so good for preventing postpartum hemorrhage. It's like a shot in the leg that apparently you guys can't give yet. We'll get there. We'll get there. So if this mom is nursing this baby and she's got this nice little flood of oxytocin, usually that creates contractions that are going to bring this placenta. And when that placenta, imagine if this is the uterus and that placenta is stuck to the uterine wall, as that uterus contracts, it's going to shear that placenta off. And when that placenta shears off, there's going to be a little gush of blood. That's really normal. Don't panic if you see all of a sudden they're going to be like 25, 30 cc's of blood. That's a really normal placental gush. It does not mean that anything, that was a cringy look. That's great. That doesn't mean that there's anything wrong. It means that that placenta is probably ready to come. If you don't feel like dealing with that placenta and you're 5 minutes away from the hospital, just don't deal with it. It's going to be okay. But if you're still 20 minutes away, then it's sort of like important that you get that placenta out, because if the placenta like wants to come and can't, you can create some extra bleeding. So if you've seen that little placenta gush and her fundus, or the top of her uterus, is like starting to move down a little bit, it's probably time that that placenta can come. So you can provide a little bit of traction. And what I usually do is like guard the uterus. So put one hand just above the pubic bone, so that if you give a little traction to that cord, you know that you're not pulling placenta or pulling uterus with it, you'll feel it. And you can ask the mom to push. In the hospital, I feel like they put one foot up trying to get that placenta out. There's no need for that. If the placenta is ready to come, then, and you give a little bit of traction, with some maternal effort, that placenta is going to come pretty easily. So again, if you're 5 minutes away and you're like, yeah, I think that placenta wants to come, but I really don't want to deal with that, that's okay. Let them deal with that. But if you're farther away, just deal with the placenta, you guys. It's okay. It's just a disposable organ. It's fine. And then, so once that placenta is out, you do want to feel a nice firm uterus, and it's going to be at umbilicus or maybe a little bit lower. It should feel pretty nice and firm, like a grapefruit. If it's boggy, like some sort of a water balloon, that's not a good thing, and then you want to firm that up, and we'll talk about that a little bit more. Questions about normal childbirth? Just this perfectly healthy baby. Yeah. This perfectly healthy baby slipping right out. Questions about that? What to do?
Sure. Let's say you're delivering a baby in the back of the ambulance while it's moving, and it's the mother's first birth. Okay. What techniques do you have for yo-yoing that can happen? Kind of like the toughness of kind of going in and out. Do you know what I'm saying?
So before the head is born?
Yeah.
That's perfect.
Yeah.
It happens. Childbirth, especially for first babies, I tell everybody, that whole getting that baby under the pubic bone is this 2 steps forward, 1 step back process. You shouldn't mess with that. That's the way it was supposed to work, because if that baby, especially baby number 1, comes blasting out, that mom is never going to be the same again.
Yeah.
Nobody wants that. But if that baby is allowed to come out a little bit, move back, come out a little bit, move back, come out a little bit, move back. That's giving the head chance to mold, because there are all these different plates in the skull that are designed to overlap each other and to sort of mold into a head shape that is more easily able to navigate that pelvis. And that 2 steps forward, 1 step back process allows the mom's pelvis to get out of the way, it allows the tissues to stretch, and allows that head to mold. It's okay. Once that baby gets to a crown, if that baby is sitting there like that, then that head is probably going to come with the next contraction. So what I recommend is, if that head has, you go from seeing that much of the head to seeing that much of the head, seeing that much of the head, and it's normal until you get to about here for that to be a back and forth process. Once you get to about here, I don't expect that baby to move back anymore. And if they do, drive faster.
Sure.
Because that can mean that there's something shoulder-wise that's hung up there. And I'll talk more about that. I'm not just going to leave you high and dry, but yeah, that baby I would expect to be born within the next contraction or maybe 2. So at this point, I would provide just a little bit of basic perinatal support, because we don't want that. I mean, if we can prevent a tear, let's prevent a tear. That mom will thank you for it. Nobody wants to tear. So just if you have a warm washcloth, a nice washcloth, just applying a little tiny bit of counter pressure to support those tissues, totally appropriate. Sorry. What was I going to say there? I don't know what else I was going to say.
What timing? Timing and pushes and stuff like that.
For a first-time mom in particular?
Sure, or any, I guess.
If you load a first-time mom up into the ambulance, it's entirely likely that even if she's pushing at that point, that baby's not going to come before you get to the hospital.
If we have a successful home birth and the baby and the mom are healthy, do they have to go to the hospital?
I mean, probably for your liability's sake.
I mean, what if mom says, I don't want to go, somebody else call, and then everybody's healthy, do they have to go?
They don't have to go, but I would love eyes on that person for the next hour and a half, 2, 3, just to make sure the bleeding is normal and baby transitions well. But I'll come back to that.
Right.
So because you might find people declining. So as far as timing, it's not uncommon for a first-time mom in an unaugmented, if they're delivering in a natural setting, for them to push for, an hour or two. That's actually pretty common for a first baby. If it's a preemie baby, that's gonna be different. Those babies come sliding out pretty easily. But I wouldn't put any strict parameters on. That being said, if there's prolonged second stage or pushing stage, we're monitoring heart tones on that baby pretty closely, and so as long as the baby sounds fine, we don't really push things. If the baby sounds compromised, then yeah, we're gonna take measures to speed that up. But what's your guys' longest transport around here? Like, what's the farthest way that you might have to travel to a hospital? Shit. You kidding me? Oh yeah, well that's a legit question.
So how many do you fly?
How many get like helicopter?
Good,
Yeah.
but the NICU wouldn't be coming,
Yeah.
so.
Interesting. Well, you wouldn't want to.
I don't think a bird would fly that out, would they? They just get back to ambulance and say.
I don't know. It seems like they want to fly everything. I'm like, it's a hangnail, you guys. We don't need to like. Okay. Whatever. Okay, so let's go over some obstetric complications. And I sort of put in here the most likely thing that I expect you guys to see. And if we get to the end of this obstetric complications section, y'all are like, oh, we might see this or this, then let me know, because I would love to like understand that that's, a concern in your world, and add this in, and we can just talk about it off the cuff too. So I would say like we don't deal with premature babies, obviously. If a mom is going into labor and she's before 37 weeks, she risks out of our care. 36-week babies are really pretty robust on average, but sometimes they need that additional like more involved respiratory support, so we transport anything earlier than 37 weeks. You guys, however, might be stuck with receiving a premature baby, because usually people are like, I didn't think I was in labor. I was only 32 weeks. I wasn't expecting to be in labor, and I just thought I was having a backache that came and went like all day long. And here it's contractions, and now she's on the verge of pushing a baby out. Things you need to watch for: be prepared to resuscitate these babies, because these babies don't always have everything in place to make that transition to sucking air. So they don't have sometimes the surfactant in their lungs that allow the alveoli to pop open. Sometimes they need a little bit of help there. And do you guys have like neonatal and preemie masks?
Not preemie.
Okay, I would consider having it. I carry the infant and the neonate, and the neonate is what I would use for a small baby. But I would consider having those masks on board, because they're going to be real hard to get like an eye gel in. So if you can do it with a mask, you want a mask for that. This baby is going to be even more important to leave that cord intact, because they need that blood volume. So if you can facilitate thermal management, in other words, keep that baby on the chest and leave the cord intact, do so. There's very, very few babies that you don't want to leave the cord intact. There'd be some like chromosomal abnormalities that shouldn't have that full blood volume, but those babies are so few and far between that you should just leave the cord intact. Leave the cord intact. Keep that baby skin on skin. And with these babies, these early babies, you're going to want to watch out for breech position, because those babies haven't had yet the time to really be incentivized to be head down. So they are much more likely to be breached than a 37 or beyond baby. So can you guys transport with baby on mom's chest?
So Boulder Ambulance has
Like a strap thing?
Yep.
All right, I can maybe see that working. Even if you need to work on that baby?
Like connects to mom,
Okay,
and then mom gets secured.
mom gets secured and then baby gets secured to mom. All right. I want to see that.
It's not here.
Doesn't need your end.
I'll send you a picture.
Perfect. So on the note of breech babies, what do we do about them? Because it's usually actually pretty straightforward, but it's a little bit of a different ball of wax. If you have a baby who's coming breech, and the best way that you can tell this is if when the water breaks, you have like thick, goopy meconium coming out, this thick, tarry black stuff that looks like they could patch the cracks in the road with. That, my friends, is a breech baby coming. So the reason that you have that meconium coming first is because now they're ass first in the pelvis and they're getting a tight squeeze, and of course their reaction is to poop. So be prepared then for a breech birth. I would, if you suspect a breech birth, first of all, encourage that mom into a hands and knees position. The reason is because if you have a mom on her hands and knees, that baby, generally speaking, is like this. She's on her hands and knees. That baby is coming like this, and they are going to birth in a way that gravity helps position the baby and helps that head pass through the maternal pelvis in a more effective way. If you have a mom on her back, it takes a lot more maneuvering. You have to be a much more involved and knowledgeable participant to catch a breech baby with a mom on her back. If that mom is on her hands and knees, you just get to stand back and watch the show 9 times out of 10. So, especially in this situation, you want to encourage her to hold off on pushing this baby out until she cannot any longer, until her body just takes over. And if you told her to stop pushing, she'd be like, I am not in charge of this. I am not doing this. This is happening to me, not because of me. And that is going to allow the best chances of that head coming easily. If you encourage that mom to push before she's physiologically unable to resist doing so, you run the risk of that cervix being dilated enough to pass this body through, because that baby is sort of going to be shaped like this. They've got the big old noggin, the hardest, most unyielding part of the baby presenting last, and you've got sort of this funnel-shaped body coming first. And so that cervix dilates with that baby. If it's just dilated enough to let the body out, but not dilated enough to let the head out, that's when you have an entrapment situation. That's the most feared complication of breech births, obviously. If you encourage that mom to get on her hands and knees, or even better yet, have her put her chest down on the ground, butt up in the air, that's going to resist that expulsive effort as long as possible. Then when she does begin to push, like I said before, you're going to want to let this baby present just without futzing as much as possible. So you just if you need to sit on your hands, do that. Whatever you need to do to not mess with this process, because likely the butt is going to present first, and then the legs, and they sort of flop down. It's really sort of unnatural to watch. They're just going to push a little bit more, and one arm is going to come, and then ideally, in short order, the next arm comes. And that's groovy, because if you've got a baby who's born this far, especially if they've got a little chest crease there, that tells you that everything up here that you can't see yet is happening perfectly. And then you might, if the baby is just sort of hanging out here, and you're like, I really would like that baby to get out, then you may do just a little shoulder press. If you flat hands right on the chest, press, it will sort of, with some leverage from the maternal pelvis, it'll pop that head out. Once this mom starts pushing, if you can get this baby born to the bitrochanteric diameter, then don't have her wait for contractions anymore. Just have her push until this baby comes. We could get into a whole discussion about physiologic breech birth, but the main thing is stand back, watch, and just make sure that you see feet, one arm then the other arm, and then you can assist with a shoulder press for the head if you need to. And then that baby goes right to mom. That baby is going to have a little harder time transitioning, because it's not normal to be born, body first. And so what you end up with is this weird circulatory dynamic where their head, has just a weird volume, a weird circulatory volume thing. And so it takes them longer to transition than a vertex baby. So just be ready to help that baby out a little bit, but give them a hot minute, because usually it'll all fix itself if you give them that first full minute, especially if you give them the mom. The pictures are gonna work. Get ready. Okay, so this is what most people would call a footling breech. I'm not going to get into the nuance of why that's a stupid categorization, but this is likely a complete breech. So if you see feet first, don't just panic. It's going to be okay. likely if you see 2 feet presenting right away, that's pretty groovy. You don't need to panic if the feet are out. The feet do not breathe. So just because the feet are out, you don't have to start timing the situation. The feet could be out for an hour. That's okay. I'm gonna give you more than enough time to get where you need to go. Once you're born to the hips, or to the bitrochanteric diameter, depending on how this baby is oriented, then you have to start timing things. Then you want to encourage that mom to, push as much as you can. Realize that this mom is on her hands and knees. So that baby's going to present with the sacrum towards the transverse. And then, stop that. Oh, and then they're going to rotate sacrum anterior. So this is a baby that's progressing well. You can thank the child. That nice robust cord means that baby is getting all of the circulation that they need right now. It's not going to last forever though, so you want to expedite things at this point. If that baby is clearly on their way out, if you can see that much of the head, they're going to slip right out with no problem. If you've got a baby that's there for a while, do that shoulder press. Just get that baby out. And then that baby is going to look folded up and goofy for a while. They can have some unusual bruising. They sort of look like they were just put through the ringer, because they were. But don't panic if that baby comes out and then they fold right back up. They've maybe been that way for a while, and it's going to take them a few weeks to unfold. Questions about breech birth?
Does it matter? Does it matter if they're feet first, butt first?
It sort of does. The type of breech most likely to create some problems is that complete or incomplete breech. In other words, a baby who is curled up with, this baby does not do breech very well. This baby's got some problems. So if they're curled up with their feet down by their butt, it's not my preferred. Or if they've got 1 foot up by their face and 1 foot curled up by their butt, that's less favorite. Ironically, a frank breech is most likely to present in a really expedient way. They are most likely to do the internal rotations and the internal maneuvers that are necessary to navigate the pelvis. If you have a premature baby and they're presenting feet first, that's a different ball of wax. Just try and keep that baby in. Duct tape, baler twine it, I don't care what you gotta do, just get to where you need to go. Everybody's like, oh, you want a smaller baby? If you're gonna push the baby out breech, you want a smaller baby? Not true. Give me a nice 8.5, 9.5 pound baby. Those are the reliable breech ones, because the body is bulky enough that they're getting that cervix completely out of the way before that head is trying to come. Other questions?
Random question to go back. Would twins always be a high risk pregnancy?
We don't always risk twins out. I've had 2 sets of twins that made it to home birth status, but it takes a lot of stars to align before we will do them at home. And I do ongoing collaborative care because they're a really dynamic pregnancy and they could risk out for a number of reasons throughout the course of prenatal care. The birth is, there are some extra risk factors in the birth, mainly that once that first baby is born, you have to keep tabs on heart rate of the second baby, and if that mom starts bleeding, the options of what you can use to manage that bleeding is limited, because you still have a baby on the inside. You've got bleeding and a baby on the inside, so we can't give PIT, we can't give,
Okay, so say you had she had a miscarriage and then she has twins, that's automatically not a home birth kind of deal?
Oh, no, not true. A miscarriage, and then a couple months later she conceives twins.
Exactly.
No, not an automatic risk out.
Just
Yeah.
curious.
We have a set of twins that's a year and some change old right now. The hardest thing about twins is getting them to term.
We just haven't decided yet, I'm not sure.
What's that?
We just haven't decided yet, we're not sure if it's twins or one yet.
Oh, all right. Well, that's
Yeah.
exciting.
Last three generations, that twins.
Oh, well, that bodes well.
Yeah,
That'll be fun.
I know.
/ a lot of work.
Interesting.
And well, it's oftentimes the case with twins that one or the other or both will be breech. So, Okay, postpartum hemorrhage, which is obviously, I don't know, sort of like the most feared obstetric complication in my opinion. I don't know, it's like, give me a breech baby any day over a solid hemorrhage. The ACOG definition of maternal postpartum hemorrhage is over 1,000 or less than that if it's accompanied by signs or symptoms of shock. So I've had moms lose 500 and like, oh, I can't get up to the bathroom without feeling woozy. I'm like, okay. But I just had a mom who was 1,300, just like that, 1,300, and she's like, I'm gonna go to the bathroom. I'm gonna go upstairs and like sit there, small baby. I'm like, oh, all right. So it really depends on how the mom is tolerating things. Main risk factors. So prenatally, if you have a placental abruption, that is a time-sensitive emergency. We do not like to see that. And placental abruptions actually increase your risk of uterine rupture. So all sorts of fun things could happen there. And then a vasoprevia is a situation where if you've got the uterus and you've got the cervix, which is of course the entrance of the uterus that has to dilate to let the baby out. If you've got a placenta that has decided to implant over the top of that cervix, and now you're getting closer to delivery, that cervix starts to dilate and dilates into that placenta, you can have like really phenomenal blood loss in a short amount of time. So these situations, you're just going to want to drive fast. That's what we try and risk these things out as much as possible, identify them beforehand and risk them out of our, because we don't want this out of hospital. Another risk factor is a history of postpartum hemorrhage. So one more reason to ask that if you're walking into a birth situation, ask if she had a hemorrhage in the past. She's more likely to have a repeat one, and you can be ready for it. Poor nutrition sets people up for losing blood loss. So ironically, the people who can least afford to lose some extra blood are the people who are more likely to lose it, which is sort of crappy, but that's the way it is. And then either a really long labor or a really short labor. Both of those have a little higher risk of postpartum hemorrhage. So do I talk about this here? We, the medications that we carry 3 different uterotonics. So we carry Pitocin, which is an IM injection. You can give it in a bag of fluids. We just don't. You can give it IV. We carry Methergin, which is another uterotonic, and misoprostol, which is actually an ulcer drug that we use as a uterotonic. We carry TXA, and we carry IV fluids that we can administer. I think you guys only have TXA, which sucks because you should have Pitocin, but we'll work on that. And the only reason I'm throwing this out there is that you guys understand, if you're coming into a postpartum hemorrhage transport, you understand like what medications we likely already have on board, what we have at our disposal. Do we have any like just first responders or EMTs here who cannot start a line? Okay. In that situation, if you respond to us and we have a mom with an IV started, what I've worked out with all the other sort of municipalities in our area, because we have a lot of first responders and a lot of EMTs, and they can't have an open line on their bus unless we're along to tend to it. So that's just what we do. We are going to ride along. We can, be in charge of that IV. And you're going to have a hard time keeping me from coming along anyway, so. Yeah.
If you're going to use Pitocin, what's the typical dose that you're giving?
We give 10 units IM in one thigh and then 10 units in another within a couple of minutes if we don't have some control of the situation. I'm trying to get it in my standing order so that we can give either 10 IM and then 10 in a bag.
We can get Pitocin 10 units per ml and then in the 1 ml vial.
Yeah, exactly. Yep, so you would give the whole vial. Yep.
So if I get the medical director.
Yeah, in the hospital they give up to 40 units, and I feel like if we're in a situation where we need 40, then we're in a situation that doesn't belong in a hospital. So that's sort of why our practice protocol is set the way that it is. But yeah, just so that you sort of know what the hospital standards are versus what our standards are. We're capped at 20, they're capped at 40. Usually if we have given one, I'm sort of reformulating the way that our postpartum hemorrhage protocol look, because TXA, the way that people are using it in the formulary is changing. So if I give one shot of Pitocin and that hasn't like really sealed the deal here, I'm more likely to start an IV and get some TXA going, and then give a second shot of Pitocin, because then you're coming at this from two different, pharmacological modalities, you're just,
THA.
yeah, which is nice. I mean, it's not a uterotonic though, which sort of sucks. Okay, so the 4 T's of postpartum hemorrhage, the first and most likely reason that a mom is bleeding is poor uterine tone. So that's supposed to say tone. But uterine atony is like the primary cause. So if you feel that uterus and it's like way above umbilicus and it's sort of boggy and stupid feeling, just give the nice firm massage. It's like circular in this downward motion. And you can ask that mom to bear down a little bit because she might like push out some clots or whatever, but getting that uterus to firm up is going to be your number one goal. And since you don't carry uterotonics, the best thing that you can do is some fundal massage. We could go through, things like bimanual compression, but you're just not, that's a really invasive thing. You're probably not going to put your hand inside of somebody's uterus. You don't have to. Usually fundal massage is going to get you where you need to go. And then realize that if there are some clots building up in there, that can actually exacerbate the bleeding and she'll start losing more blood. So if you can do some fundal massage and have her give a little push, you can get those clots out, and that usually curtails the bleeding. Obviously, if you can start 2 large bore IVs, do so. And then she's better positioned to receive more medications when she gets where she needs to go. Trauma is the next most likely reason to be losing a ton of blood. So if she just pushed the baby out, especially if it's that first time mom, and she had a nice little tear, those can bleed like a mother. Those can bleed. So realize that might be part of why she's bleeding. I would say don't go digging around in there to find out, because once that wound starts to clot, and it usually will, you don't want to disturb things just to know if there's genital trauma that's causing the bleeding. Just let it be. Just let it be. Somebody, when you get where you need to go, is going to figure out why she bled that much. But if you suspect, if it's an obvious laceration and it's actively bleeding, you can pack it. Pack it with sterile gauze. Count the number. If you only have 4x4 gauze or something sterile to stick in there, count the number of gauze pads that you put in so that we know that the right number of gauze pads come back out. If you have a bag of rolled up sterile Kerlix, that's a great one to pack a genital laceration, but you just want to stop that bleeding. And then if you do feel like it's trauma, make sure you're extra diligent about making that uterus nice and firm, because you don't want bleeding from 2 sources. If you can't really do much about this bleeding, because nobody's going to suture right now to stop that bleeding like they would in the hospital, then at least pack it and be on top of that uterine bleeding so you're not losing blood from 2 sources. Questions about that? Tissue is third most likely, so if there is a retained placenta, that can cause a fantastic amount of bleeding. One more reason to not clamp and cut the cord right away, because here's the thing, if that baby came out and you're like, oh yeah, let's clamp and cut the cord, and you clamp it and cut it, and you retain all of this extra blood volume that I told you about that's supposed to be in the baby, now it's still up here, that placenta cannot shear off the uterine wall as effectively as it would if you allowed it to deflate. Then it's going to slide off real easy, 9 times out of 10. A retained placenta is not something that you want to deal with. So let the baby get all of that blood volume, let that placenta sort of deflate, let that uterus shear it off, as easy as possible. We talked about delivery of the placenta already. Retained products of conception. One more reason that you don't want to pull on the placenta like we talked about before is because you're more likely to leave parts of the placenta behind. If you're pulling and yanking on that placenta before it's fully ready to come, parts, little cotyledons, little parts of that placenta can leave stuck to the uterine wall, and now you've created a just phenomenal postpartum hemorrhage equation. So just let the placenta come when it's ready. Medications for this would be pretty similar to, just regular uterine atony, just because we want to create cramping of the uterus to expel placental fragments. And thrombin, this is just again, one that you don't want to have to deal with, because this is going to be a really tricky hemorrhage. Basically, for whatever reason, the body does not have the blood clotting capabilities that it needs. And there can be inherited disorders, obviously, but Acquired ones, preeclampsia, is much more likely to result in a really, pretty tricky postpartum hemorrhage, and consumptive DIC, disseminated intravascular coagulation, and amniotic fluid embolisms are things that, like, even if that happens in the hospital, the outcomes are dicey. So hopefully they don't happen out of hospital because, ugh. 2 large bore IVs, TXA is good for this one.
I just want to make one comment. Just remember that the bleeding from any of those things can happen really, really fast. So you need to get your IVs in. quickly.
Yes, because once you've lost that, that's really hard. I mean, you can pop pretty much anything in the AEC, right? But if you want to get a nice form, get it before she's lost a lot. Any questions about postpartum hemorrhage? Because that's like more than likely what you guys are running into. And that's more than likely why we're transporting somebody too, to be honest. I don't sit home with people that are bleeding and not responsive to like my initial steps. Questions? Neonatal resuscitation. So if the child is born and they need a little help breathing, I want you to be able to know what to do and identify the babies who need some help versus the babies just who need a hot second. So it's true that 10% of babies are going to need some help. 10% of babies when they're born. And we're talking about like low risk, normal vaginal births right here. I'm not talking about that premature baby. I'm not talking about the baby born to the drug addicted, mom. Like those babies are likely going to need a little bit more. But on average, 10% of babies are going to need a little help. 1% are going to need more extensive resuscitative measures. So this is a baby who just needs to be skin on skin with mom. They have decent muscle tone. In other words, like they're not floppy. They're collected. They have some tone to them. They look like they want to be there. Crying is good. Unlabored breathing is also good. So don't feel like they need to be hollering at the top of their lungs. If they're breathing, that's cool. Let them breathe. We don't need to harass them and make them cry. They might have mild peripheral cyanosis, like I sort of demonstrated before in the picture. It's normal for their hands and feet up until like the end of the first week to be blue sometimes. That's normal, and they should have a heart rate above 100. So if you, where is it? Okay, we'll touch on that in a second. So a baby who needs help is a baby who is born floppy. Don't trust a baby who's born floppy. Sometimes they'll sort of rally, but we don't want to sit there and wait and find out, be like, oh, is this baby going to get their shit together or not? If they're born like this, help them out. If their respiratory effort is there, but it's really gaspy, or obviously if it's not there at all, be ready to help. If they are peripherally or centrally blue past that first minute, that's a concern. And anytime you have a heart rate below 100, you might give them the first 30 seconds then, but if they have a heart rate in the 60s, that's a baby who's going to need some help, more likely than not. So if you don't have an infant stethoscope, you just didn't grab your stuff, you can palpate the cord. So imagine this cord is coming out here. If you palpate with your thumb and forefinger, you might very well be feeling your heartbeat. But if you palpate with the sides of your fingers, you're feeling the pulse in the cord. So just sort of think about that. You don't necessarily have to have a stethoscope. You can assess this way. And sometimes that's nice because if you're working on a baby, you don't want to like be alternating between like stethoscope and not. You just like quick get an assessment through the cord. It's the easiest way. Okay, so point number 1 is assess the need for help. Okay. Point number 2, position the baby. So if you have a baby who's like, maybe this is a quick birth at home and you're trying to get everybody loaded up, but that baby needs some help and they're like on the squishy mattress, you can't help that baby. They need to be positioned properly. So you want to get them in a position where they have their head in a slightly extended position, so sniffing position. I'm sure you guys are all familiar with that, but if you try and resuscitate this baby, their airways are so tiny that the smallest little head flexion is going to mean your ventilatory efforts are not effective. So if you get them on a shoulder roll, then get them on a firm surface. Even if you have to put them on the floor, that's better than on the bed. Don't resuscitate a baby on the bed. Firm surface, put a shoulder roll, not a neck roll. You're not putting a pad underneath their neck. You're putting a shoulder roll so that their head tips back. And then you want to wipe that face off, because if you try and bag that baby with a slippery, nasty face, that mask is going to slide all over the place. You're not going to get a good seal. What do I have next? Okay, so realize that the first at least 5 to 6 breaths that you give that baby are just taking those alveoli, which are filled with lung fluid, and displacing, like getting the lung fluid out and replacing them with air. So it's just a volume exchange. You're not going to see chest rise in the first 5 or 6 inflation breaths. You're just replacing what was there with something else. After that, then you've got lungs that are like breathing. So now, after those first inflation breaths, you should see chest rise with every ventilatory effort. So the way that you count those inflation breaths, because they need to be a little bit more pressure for a little bit more time, you want that manometer to go up just shy of the red, because it takes a fair amount of pressure to displace that lung fluid. You want to go up to 40, and you want to breathe, or you want to like time it, so a little more pressure for a little more time, a little more pressure for a little more time. Those are slower, slightly more pressure breaths. And that's going to most effectively inflate those lungs. If you need to move past that, and you can refer to your NRP guidelines for this. I don't know, I think we looked at those, right? What we would do is, once you move past those first like inflation breaths, generally speaking, you're going to get an infant response. You're going to get a baby who spontaneously starts breathing, or they start, crying. Obviously, at that point, you can discontinue what you're doing and move to observe. But if you have a baby who, after those first 5 to 6 breaths, is not responding, then reevaluate, is your mask positioned properly? Do you have a good airway? Are all, reposition your mask and make sure that you're getting a good seal. If you feel like you are, then you move right into ventilation. So that's going to be breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. And for these breaths, these ventilation breaths, you're only going to go up to like the start of that yellow range. That's good enough for those ventilation breaths. Their lungs are so tiny, they don't need a lot of volume. So you want to do at least 15 seconds of effective ventilation breaths before you reevaluate, because it takes time to evaluate, and that baby just needs respiratory support at this point. So do 15 seconds of effective ventilation breaths. And then check the heart rate. If that heart rate is below 60, automatically go into CPR, to full chest compressions, the whole 9 yards. What was I going to say here? On the note of those lungs being tiny and requiring a little bit of air, if you are the only provider there and you feel like you're going to have to move on to chest compressions as a really compromised baby, and you are the only person that can manage this, you're going to have to just do mouth to mouth, because you can't do all the things with a bag and mask. So if you are ever doing mouth to mouth on a brand new baby, you only use the air that's in your face. It's not like, they have such tiny little lungs, and you can cause a pneumothorax if you're just putting shit tons of air in there. They can't handle that. So you literally just use the air that's in your head. Just don't breathe from your lungs for those. But that's the best way to manage resus if you're going to end up doing CPR and you're the only person there.
Katie, before you go on, so you have a baby that's in distress and you give them 15 seconds of breaths.
Mm-hmm.
How likely is that to happen or help versus you need to do CPR? How many times do you?
I have only done CPR, like full out chest compressions, on one baby in 18 years. Now, a lot of that is because we risk people out. If we have a baby that we know is gonna require some help, we don't want them born at home. So a lot of that is just our, selection process. But a lot of it is that babies were born, like, they want to breathe, and usually with those initial steps, like 90% of the 10% of babies who need some help are going to be off to the races with just those initial ventilatory efforts. I think I've only moved on to ventilation in 18 years, less than a dozen times. This is pretty unlikely. If you have, like a full team of people there and you're moving on to CPR, then you want to consider, moving on to an alternative airway. How many would intubate a newborn? that's what I'd like to see. Because y'all would suck at it. You should only intubate babies if you're doing it on the regular, because you can cause more damage than you can fix. You can puncture stuff, you can misplace it. It's just not going to be good. But eye gels are a good and pretty easy alternative airway that pretty much anybody can manage. You're all familiar with an eye gel, yeah? So you want to carry the size 1 for infants. That's probably going to be too big for a preemie. I don't know. I think it's down to 5 pounds for the size 1s. So if you're moving on to CPR, then you want to be considering an alternative airway if it's in your comfort zone. If you've placed other eye gels before and you feel like you can get this in a pretty decent flow, consider this. If you feel like you're going to fumble around and you're going to drop it and you're going to need to, just don't. Then keep doing what you're doing that's working. So if you're doing CPR on a baby, I know a lot of CPRs move to compressions only. That is not the case for newborns. They need ventilatory effort. They need oxygen. So if we are moving on to chest compressions, we're also attaching oxygen and using 100% oxygen to resuscitate. All other resuscitation that we're doing is with room air. And that vast majority of times that's fine. But if we're moving on to CPR, then we are using 100% oxygen. And the count for this is going to be pretty quick, and you got to coordinate this. So it's going to be 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe, and 1 and 2 and 3. And it's 1/3 of the chest diameter, right at the nipple line. You can do the 2 fingers method, or you can do. I think they're really encouraging people to use the 2 thumbs. I think that's clumsy as all get out, but whatever. You guys do you. But you have to coordinate those breaths and those compressions pretty effectively. The one time that I did compressions on a baby, we had a NICU intercept en route, and they couldn't get the timing right. I tried to let her take over bagging that baby, and finally we're all like, how about I just keep doing what I'm doing because that's working, and I just kept doing mouth to mouth the whole way to the hospital, and it worked, and that baby came with lovely blood gases. Thank you very much. So 1 and 2 and 3 and breathe, and you gotta time that and breathe in, so you're breathing on the whole and breathe in. So it's gonna be 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe. Obviously that's 2 different people doing this, not one person trying to go back and forth in this goofy manner. So you want to use quick effective thrust, obviously like any CPR, use 100% oil. Move to the next slide. Thank you. If you're moving on to chest compressions, don't stop and evaluate that baby until you've done chest compressions for at least a minute, because it takes that long to get your perfusion up to where it should be. And if you have just finally got the perfusion up to here and you stop to evaluate that baby, now you got to start right back and bring that baby up again. So a full minute before you even stop and evaluate. And move back to just ventilation if that heart rate is above 60. 60 is not comfortable. 60 feels yucky, but that is when you should stop doing compressions and just ventilate. Keep these babies warm, and I'm gonna talk a little bit about this because so if you have a compromised newborn or a baby that we suspect for any reason has been through a hypoxic event, if at any point the oxygen has been cut off from this little noggin, we want to maintain their warmth, but we don't want to go through big steps to warm them artificially. Because here's the thing, if that baby has had some hypoxia, their brain, there's a chemical reaction happening in here that is actually sped up if you warm them unnaturally. So what will happen is if you just maintain them warm, keep them warmish, you get to the hospital, they will cool that baby if that baby needs it to slow down those chemical changes in the brain and hopefully curtail the brain damage that could otherwise happen. If you warm that baby, you're accelerating that damage. So keep that baby chest to chest. That's the best place for thermoregulation for a baby, especially a potentially compromised one. You're not like packing heat packs around, you're not putting on a thermal pad, you're not artificially warming that baby, you're just maintaining the body warmth that needs to be there so that they're not dealing with a cold baby when they come in. Does everybody get that? Because if you've had a hypoxic, event, you could be exacerbating the brain damage in the baby by keeping them really warm. And then the other thing is like, just don't give up on a baby before your higher level care. A, it's not inside of our scope. And nobody in here can call a death. You can't say, well, it's too bad for you. It's not going to work out too well. It's just like hold off on things because it doesn't look good for this baby. Babies are really pretty resilient and pretty forgiving. If that baby is getting some perfusion, even if you don't think that they're doing well, you just keep doing the thing until you get to higher level care, because even babies who've had a really rocky start can, make up for that with the proper therapies and the proper, technologies in the NICU. I had a situation out in our area where, we had a midwife respond to a compromised newborn, and then she just didn't think that this was, she thought this baby was going to die, and so she sort of held off on resuscitative efforts, which blows my flipping mind. And then the EMS crew walked in, and she's like, there's no way this baby is going to live, and so they didn't do resuscitation. And then the paramedics came in like 2, 3, 4 minutes later, and they were able to work on that baby and get a heart rate in about 2 minutes. So they stuck in an IO and they intubated that baby and they flew that baby to Marshfield. But the time that those two provider groups did not provide resuscitative care was the end for that baby. That baby had sustained too much damage, and they kept that baby on life support for, a day and then removed. But that outcome could have been so much different had people not walked in and said, well, sorry for your loss. That's not appropriate in anybody's stretch of the imagination. So I don't care, like even if I walk into a situation where baby's already born, I wouldn't care if they said this baby never took a breath. I would resuscitate that baby until higher level care, regardless. That's probably not a soapbox I needed to get on. Maybe I just needed to get out of my system, because I think y'all would do it. Okay, questions about resuscitation?
I don't know if you deal with it much in your practice, but see, or have you had to deal with any like opioid dependencies with?
Yeah, so I've got just like one slide for that, because I haven't. And probably that's just because we have this like little cherry-picked, self-selected demographic that generally steers clear of opioids. But that's not to say that everybody is immune, and you guys are probably way more likely to run into that than I ever am. And so you would give Narcan like you would to anybody, even if that mom is pregnant, even on the verge of pushing a baby out, because if if she's not with us, that baby's not going to be with us either. So we don't really know too much about the lasting effects of Narcan administration during pregnancy, and even like in the, just in the labor process. But bottom line is, you have a super compromised mom, you're gonna have a super compromised baby. So give Narcan like you normally would. You can't give Narcan to a baby.
And it's just, they're typically gonna present just, need some respiratory support.
Yeah, yep, and get that baby to, they're gonna need support afterwards, probably, but.
Where I came from, so, a little over a year ago, so this would have been spring of '24.
Okay.
We did training with our OB department, and the scary statistic there, half of their deliveries required some Narcan.
No.
Half.
What? That's mind-blowing. Well,
Not here, that wasn't here.
where was that?
Wisconsin Rapids. Probably.
Really?
Yeah. That was a hospital. We get, still
Yeah.
Wisconsin Rapids, we 82 deliveries a year.
Yeah. Huh. Oh, no. Other questions about newborn resuscitation? I think there's something else I was going to say. I'm forgetting something there. But, cardiac arrest during pregnancy. If you have somebody who's pregnant and in cardiac arrest, you do, pretty much everything like you normally would, except for they are still, last I heard, recommending breaths for pregnant moms. So it's not compression only, unless like you're just like super uncomfortable doing breaths. Obviously compressions are better than nothing, but they are still recommending 30 and 2 for pregnancy. Pad placement is the same if you need to progress to an AED, and the only difference now for CPR with a pregnant woman is we're not recommending left lateral tilt anymore because it's really hard to get downward, like direct downward pressure and get that same cardiac pressure. So we're recommending now left lateral displacement of the gravid uterus. So if you have that mom supine on the ground, you have somebody displace that abdomen to the left, and then you proceed with CPR with chest compressions like you normally would. Because that's getting the weight of the gravid uterus off of everything that needs to, and just doing the same thing as that left lateral tilt in that regard, but still able to provide better quality compressions. Questions?
How far? Like you said, left lateral displacement, like.
I mean,
Push it off, so.
just
Like the
just
keyboard
as-
was like crazy.
yeah,
on
you
the
want to just
side.
remove the uterus and set it to the side would be great. That's gonna be different for every mom. If I've got moms that have had 7 or 8 babies, well, you can displace that uterus quite a bit because it's been there, done that, But like a first time mom, you might not be able to much, but it's slightly better than nothing.
If you're the only one there, is it better to leave them just flat then on their back and not worry about displacement?
I would, and I say this because I know a lot of moms who are like, if that gravid uterus was really impeding circulatory flow to the extent that we think, we would have a lot more moms who as soon as they lay on their back, they're all of a sudden feeling nauseous or lightheaded. And that does happen after a while, but most moms can lay there, like if I'm doing a prenatal exam, they can lay there for quite a while and not feel the effect of that, the circulatory effect. So I would say if you have to prioritize something, prioritize the quality of your compressions and not uterine displacement. That's just a hunch though. Hopefully you have somebody else there. And then opioid, pretty much just treat as you would anybody who said we can save that mom, because without that mom, that baby's a lot of luck. What questions do you guys have, either about Windyhill Midwifery, about home birth in general, about complications, about what to expect if you walk into a transport? What do you want to know from me that we haven't touched on?
I will say for our Northwoods people that are, or any of the services that are following our protocols, Katie helped write the OB protocol. So everything that she's been saying is very much integrated into that protocol.
I think probably the biggest difference is going to be in most EMS protocol that I've seen, they want you to clamp and cut that cord. They're like,
And so
I'm gonna cut the cord. Like this baby is going to exsanguinate into the maternal circulatory system. And for Pete's sake, do you not understand maternal fetal physiology? Like there's a distinct separation between the two systems here. We don't need to clamp and cut that cord so that this baby doesn't, bleed out. That's the stupidest thing I've ever heard. Leave that cord intact. You'll be best served.
So Jess, in our protocol, if I recall correctly, we have this whole section about the normal birth. We do that on scene as opposed to in the ambulance because it's easier
if it's imminent.
if it's imminent.
Yep.
But with breech, we transport and do what we can back, as it says, transport in that part of the protocol.
So what that is, because breech isn't typically very as like if you walked in and the mom was pushing the baby out, obviously you're not gonna load them in the back of the ambulance. But if you see a foot
Yes.
or a butt,
Absolutely. Yep.
And then just do your best with
Yep.
the ambulance.
yep,
And if it looks like that birth is imminent, I mean, I don't know how you guys need to work this from like a restraint perspective, but the idea of a breech birth in a supine position is just like you're not gonna, you don't want that. It's just more maneuvers are necessary to get that baby out, and it's
with big seatbelts.
there you go. There you go. Get that mom on her hands and knees. Everything will be easier if you've got that baby coming butt first, feet first, whatever. That's a good question. What else?
Will that always be the case when you see like a black tarry?
Almost always. I've never seen like flags. I had a breech once. It was, the baby had turned in labor, and the dad called me. He's like, I can see the head. And what he couldn't see the head, he could see the amniotic sac filled with meconium, and it looked like a head with hair. Those babies just, they poop. It's a protest vote. They're like, this is not comfortable. And yeah.
Babies can be born with MEC.
Yeah, babies can be born with MEC. And so is it anywhere in your protocol that you have to suction for MEC?
Yeah.
Okay, that's not even recommended. It's not recommended even in the United States NRP guidelines anymore. So if you see MEC, that in and of itself is not that's not a reason in and of itself to suction a baby. So we carry just the bulb suction. These things I carry simply because if I have to suction a baby, I want to be able to say that I did this to protect my own ass. It's just liability. Let's bulb suction this baby. But they're only clearing secretions in the mouth that baby could very easily clear themselves unless it's an extremely compromised baby. A compromised, like a neurologically not intact baby is not going to be able to expel contents from their mouth. That would be a candidate for a bulb suction. Any other baby who needs suction is going to need like deeper suction, and for that I carry a Deli. I don't think.
Meconium aspirator.
Okay.
And we have a size 6 Deli.
Okay. All right. Okay. If you really need to suction a baby, just go to this, because this, if you have in any way a vigorous baby, they can clear their own airways. So this is the recess bag that I use, and the nice thing about this is it has this foam positioning board, and really like all sizes of babies fit on here pretty handily. I've had like a nice chunky 9.5, almost 10-pound baby on here. I'm like, there's no way we're gonna squeeze this kid in here, but we did, and it was lovely. And so when we transport with this, we just take the whole shit. We get one person on this side, one person on this side, and we, haul out to the ambulance just like this. It's lovely because then we've got, oxygen going with us. We can continue on with any respiratory support that we need to do. This is pretty handy, and then I've got my maternal O2 stuff in this pocket. I've got, infant advanced airway management here, thermal management, suction. And we were looking at with Marifire, I was trying to see if we could strap this onto their gurney. We couldn't figure out how to make it work. But this is a really handy thing. I would consider investing in it since you guys are so far away from help if you need it. Like, what in the world? I think it's really clever. It's a nice way to transport with that sniffing position just like built in. What else? I guess they're going easy on me.
So you said suctioning the airway, if we need to, would that obviously be on more of a lower suction setting?
Oh yeah.
Yeah.
Yeah, I don't even remember what wall suction setting they use. If you're just using a DLE, it's just really it's gonna feel intuitive, because you'll understand when you've encountered resistance. It's just more intuitive. The DLE, I feel like, is the way to go for a non-trained person, versus wall suction is just really trickier. And I would suction a baby if you feel like you have to move on to advanced airway management. I would suction. If you just need to give a few breaths, you can usually do that without suctioning. But if you've given those initial breaths and it's not, you don't feel like the breaths are going in, maybe worry about the quality of that, then I would suction and then move back to breaths.
And what minute mark again is the central cyanosis? Like if we're not seeing improvement?
You shouldn't see it past a minute. You should be seeing like vast improvements,
Sure.
if not resolution by a minute. Yeah. And I would combine that with like a baby who has no tone. If you're seeing cyanosis past 30 seconds, I would intervene. There are some people who are like, oh, give them a full minute. I'm like, that's not that. I'm helping this baby out because that's not comfortable. Like if you ever can't breathe, that's not a fun position to be in. So why don't we just like help them out a little bit? And it's not gonna hurt. I've had babies who had like an okay respiratory effort. They were breathing, but they were just like super crackly and just didn't look comfortable. with the whole situation. So I've given them 5 inflation breaths, even if they are breathing, and you can like feel it clearing their airways. And I don't know, you should just imagine how that must be an improvement. If you're trying to transition all these other things and doing it while being like not super comfortable breathing, just give some inflation breaths. It's not gonna hurt them.
Yeah. You should get the pressure up to 40.
Just shy of 40. You don't want to go past that because you don't want to cause a pneumo.
Sure.
Yeah, but up to 40 is what you need to clear lung fluid.
How about vitals? Pulse ox?
Well, yeah, so pulse ox, so O2 sats in the first hour are lower than what you would think. I mean, if I've got a baby that we're working on and they've got a 90 or 92% in that first hour, I'm like, okay, we're doing okay. 95 or 96 is better, but you don't expect to see 98, 99, even in a healthy infant. They have a longer transition. Their circulatory system, like when you think about the fact that they have to go from getting all their oxygen through the umbilical cord, they have to move from that to getting all of their oxygen through their mouth and then their lungs. There are 3 main structural changes in the heart that have to happen in order to facilitate that circulatory transition. And sometimes that doesn't happen right away. There are things closing off and things opening up, and it takes a hot second. So we sort of don't expect O2 sats above 96, 97 for the first, can be up to 12 hours. I'd have to look at the NRP flow to know exactly what they should be at any given minute.
Isn't it like 80 to 85 in the first 10, 15 minutes?
Yeah, it's not a fast process. Yeah, so you shouldn't. It's important to understand that, or at least to keep that in mind, because you don't need to put oxygen on these babies for like a 92% O2 sat. They don't. It's actually sort of a neurotoxin. We don't even give blow-by anymore because that's not what your baby is needing. Your baby is needing ventilation. If they're not satting well, unless we have something like really tricky, like persistent pulmonary hypertension or something like that. It's been years and years and years since I've given blow-by, because generally that's not fixing your problem. It's making you feel better. It's maybe making them pink up a little bit, but it's not solving the problem.
At what point are you, do you check glucose?
We would. I actually have to look up the ranges because we check it so infrequently, but I do glucose monitoring for any baby that's over 10 pounds. In the hospital, it's over 9 pounds. And I just leave a glucometer with those parents and tell them if it's anything out of this range, give me a call. But I've never really had to do it in combination with a transport because it's just not going to be my highest priority. They're going to check that in the NICU when you get there.
I think it's down to 40 is normal.
Okay.
For the first.
That sounds right. I'd have to look, but it's just not something. If we're transporting, that is like the lowest thing on my list. We're just going for basic support until we get to where we need to go. I mean, I guess unless it's a extended transport time, then it's probably willing to at least take a glucose. Yeah, that's a good question. What else? If you have a baby with any orofacial defect, consider moving more quickly to an eye gel, because sometimes those babies with orofacial defects can have tongues that are set back, they can have genital atony, they can just have some other congenital just sort of weirdnesses, I'm sure that's the technical term, congenital weirdnesses that make it hard to get a mask to fit effectively. So move to an eye gel quickly if you feel like that's the problem. But the other thing to consider is if you have a baby that has some orofacial defects but doesn't necessarily need that extensive respiratory support, consider transporting them prone. Because if they have, like Down syndrome babies, they're going to have poor tone and they're going to have like that thicker, farther back set tongue. They can tend to occlude their own airway if they're supine, but if you put them prone, everything sort of falls forward and they can usually maintain their own airway that way. So if you have a baby that is desatting supine, turn them prone, transport them like that. And oftentimes they don't even need continued respiratory therapy once they're on their bellies. What haven't we gone over? What else might you run into? A number of things. All right, we've got experts now. This is great. Anything else? Eat the food then.
All right, guys.
What was that?
Thank you.